Hello, everyone, and welcome to today's Keynote webinar titled Precision Medicine as a Population Health Tactic. This webinar is part of the 10th Annual Genetic Virtual Week, and I'm Susie Valdez of Labroots, and I will be your moderator for today's event. Today's educational web seminar is presented by Labroots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to first participate by communicating with other attendees using our new live chat feature during this presentation. You can find that live chat located on the right of your screen. You can also participate by submitting as many questions as you want during this presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have any trouble seeing or hearing this presentation, just click on that Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located in the Abstract window below the presentation window and follow the process to obtain those credits. Without further ado, I now present today's speaker, Dr. Howard McLeod, an Executive Clinical Director at the Precision Health Intermountain HealthCare System and Professor of Pharmacy and Medicine. For a complete biography of our speakers, please visit the Biography tab at the left of your screen. Dr. McLeod, welcome. You may now begin your presentation, sir.
Well, Professor Valdez, thank you so much for the kind introduction and for all that you're doing for Labroots. It's exciting to be a part of this once again. It's really a wonderful tradition to have these sessions available and available broadly so that many different people across the world can participate and benefit. I'm going to talk a little bit about precision medicine, but because that is the session, of course. But I want to mention one thing in particular, some disclosures. So I am on the board of directors of a couple of companies, one publicly traded company, as well as some privately held companies. I've also been a scientific advisor to several companies. I've been a speaker to Illumina, one company, and I'm in debt to my wife. So when we talk about population health, it's one of those terms that gets thrown around, but hasn't really been defined very well. And you can see a definition that's listed there on the screen, but really the key point to me is you're looking across a population of people and trying to understand their risks and how to deal with them. And so when I look at, if you look at a population and you're just looking at heart failure or just looking at breast cancer, that you're looking at populations health. So there's populations within the greater population that you're trying to work on. So but by looking at population health, you're really looking at the entirety. So it's not one disease, it's looking across patients. It's also bringing in other factors, their geography, their space, what's available to them. So whether there's a food desert or a pharmacy desert where don't have access, that would be an important part of that. In addition to how do we deal with the health of a population. And so I will go and be focusing mainly around precision medicine, some specific topics, so populations health, but then at the end, morph into population health and talk about some strategies that we're doing to look across a large group of people and deal with whatever they may have in terms of their risk. Now, some of this data is going to be in the context of the Intermountain HealthCare System. Recently, there's been a merger such that Intermountain is now across 7 states in the United States of America. You can see the states there. The dots are some legacy pieces in terms of what they used to be. But really, we have an ability to think about populations across this area. Urban populations, a lot of rural populations. We have populations that are underrepresented in clinical trials and in clinical studies. We have populations that are in environments where there's a high risk of certain diseases, infectious or otherwise. And so lots of opportunity to think about how do we do things better in terms of delivering care. And so while there's an academic element to what we're doing, there's also a practical element. And there's no reason why science can't be practical. You know, often we're instructed to do science and then throw it over the wall by means of publishing in peer-reviewed journals, but then hoping that someone accidentally finds the information and applies it. Well, you can do both. And so I encourage you to think about your environment and how you can do science that matters in terms of taking it all the way to helping individual people. Now, precision medicine really has evolved a lot over the last decade. 10 years ago, biobanking, where we took samples from a patient, put it in a freezer, attached it to a data warehouse so that we now have the electronic medical record. That was precision medicine. That was really just discovery work, but it is very much focused there. And then we started sequencing some genomes, looking at pharmacogenomics, so which genes affect which medicines. Then we started sequencing some tumors because there's a few genomic variations that were required in order to get access to certain FDA-approved medicines. And then, of course, we started sequencing lots of genes and then started doing non-invasive prenatal testing. And then the list starts really expanding from there, looking at everything from solid organ transplant genomics through to which pain medicine, which antidepressant one might pick. Even in the context of the neonatal intensive care unit, where most centers now, at least in the United States, are doing a rapid turnaround whole genome analysis. And I'll allude to that in one slide a little bit later. But really things have expanded in terms of precision medicine. It's no longer a research exercise, but rather is something where the practical application is starting. And then as the science grows, more and more application is happening. Now, when we look at the clinical problems, especially focusing in this time on treatments, on therapy, medication therapy in particular, the clinical problem is actually a wonderful problem. And that is that there are multiple active treatment regimens for most diseases. Now, I know you have your favorite where there have no therapy and we need to do something about that. But if you look at something like high blood pressure, there are over 100 FDA-approved drugs or drug combinations available for treating high blood pressure. So which one do you pick for an individual patient? You can look at which ones you're familiar with as a clinician. You can look at which ones are maybe the lowest copay or the lowest out-of-pocket cost for the patient. But really what we want is a better way of deciding this medicine is likely to have the biggest impact on the problem that we're trying to solve going forward. We still see variation in response. So half the patients that we try with that high blood pressure medicine will benefit. The other half need a second or a third medicine, sometimes even simultaneously, in order to get the benefit. And so, again, lots of opportunity for growth and perfection as we move forward. Toxicity is also a major factor. We have patients whose disease is under control, but the therapy needed to control the disease is causing them side effects that are just too much to bear. And so they will stop therapy even though a great benefit is happening. And again, can we predict that? Can we try to see that ahead of time, make a change, and do something? And then, of course, there's the issue that none of us want to talk about, and that is that these therapies cost a lot of money. And in certain areas like cancer, the therapies can be as much as $20,000 per month. Other areas where generic drugs are used, it can be much more reasonable. But we have to make really important decisions. And how do we achieve control of the disease in a way that it gives a good quality of life, minimal toxicity, but is also affordable. And so whether the financial piece is at the individual patient level, as it is in some countries like the United States, or whether it's at the national level, as it is in most other countries with their national drug formularies, the decision still has to be made. And so again, how do we hit that perfect spot? And if I knew how to do it, you'd already know it. I would have told you. But we have some ways of trying to achieve this goal. Now, I just want to remind you that probabilistic data is really what drives a lot of these decisions. So we're not looking for a perfect biomarker that will tell you exactly what someone should and shouldn't receive. We just want to enrich for the chance, for the probability of a good thing happening compared to a bad thing. And so that's what we do with a lot of interventions. So we see a patient with uncontrolled glucose, we try exercise, we try diet. If that doesn't work, we try medical therapy. We don't wait until they go blind or they lose their kidney. We see uncontrolled glucose and we act. Same thing with statins for primary or secondary prevention of heart attacks. You see the problem of elevated cholesterol. You intervene before you get the heart attack. as a way of trying to decrease the probability that it ever happens at all. Same thing with antihypertensives and stroke. Decrease the probability that a stroke will happen by controlling their blood pressure. And so that concept, I like to use the example of when you take your children bowling, you put down the gutter guards, you put down the little bumpers that are alongside the bowling lane. This doesn't mean that the child will get a strike when they throw the ball down the lane, but it means that the ball is not going to fall in the gutter, and they're likely to at least hit some pins in order to get that analogy fully. And so again, can we make it so the probability of success is high, the probability of failure is low when we're making these decisions? We use this concept for screening. So with increasing age, you have an increase in risk of colon cancer. You see the magic line there at about 45. That's when you start making plans and encouraging patients to get colonoscopy or a stool-based DNA approach to try to better understand what is the risk of these cancers and do something about it early when it's much more treatable rather than waiting until someone has something bad that has happened. And so the concepts are there. We're already doing it, but how do we apply it in terms of precision medicine? Now, I showed you this list before. I'm going to focus in on three particular areas of the list. A little bit on tumor sequencing and what we've learned from that. A little bit around pharmacogenomics and what we've learned from that. And then very briefly, just have one slide on the application in the neonatal intensive care unit, because that's opening up a precision medicine population health approach in even further as we go forward. So the oncology paradigm, the cancer example, is relatively straightforward, even though the technology is quite complex. And so the linear knowledge there is you have cancer cells, you can extract the DNA to do a genomic analysis, and then you can find some alterations. So in this case, the HER2 gene is amplified, the P53 gene is mutated. You have some other alterations shown there in numbers 3, 4, and 5. Some of these have medicines associated with them. Some of these do not. But you can now take this information and prioritize a certain medicine over the other options in order to increase the probability that you will control the cancer in a meaningful way. And so this concept has now become routine in many of the developed countries and is starting to get some traction even in countries that don't have the same resources as you might see in the developed world. But this idea is already here. The way it's being used is partly around the FDA-approved therapies or the regulatory authority approved therapies. So if you have a drug that is only available to patients with a certain alteration, an epidermal growth factor receptor mutation, or a ALK gene fusion translocation, those types of alterations, you only if you look and have the genomics can you then use that medicine, and they're very active in that context. There's also looking at resistance. So there are certain drugs that work in everybody except if the tumor has a KRAS mutation or some other alteration. They will not work. You can avoid those therapies in that patient. Many clinical trials nowadays are using biomarkers, and so the data is being used to identify which trials a patient should get on. And then there's also what's so-called off-label, although I like to call them no-label scenarios, because you have a situation where the patient has exhausted all of the regulatory authority approved therapies. Maybe they're not eligible for a clinical trial, but they still want to be treated. They're still fit. You still can offer them some hope and can use genomics in that way. We also have prognostic data coming from here, especially in the area of leukemias. And then lastly, as I'll allude to, you can use some of the alterations in pharmacokinetics or pharmacodynamics in terms of what is now called pharmacogenomics to try to understand which therapy, which dose, at which interval as you're moving forward. Now, there is data that has been produced around these areas. So this is a study from a couple of years ago in the journal JAMA. And what this showed is that if you have lung cancer and you had your tumor sequenced and there was a driver found, so a gene that is driving the cancer forward, and there's a therapy that stops that driver, then your outcome is shown in the orange bar. You had the superior outcome in that case. Now, if you have your tumor was sequenced, you have a driver, but for whatever reason did not get the therapy, your outcome is much inferior. And matter of fact, it's the same as if you didn't have a driver at all. So basically, the opportunity was lost in terms of having a better outcome for the patient because there were specific precise precision medicine opportunities that were identified in that context. And so this was just hammering home that it's not just that we need to sequence, but we need to make sure that access to the therapy is there in order to really realize the benefit, the public health benefit, the population health benefit in the context of these patients. Similar data across a variety of solid tumors. This is data from Derek Haslam from a few years ago, where he looked at 12 patients with 12 different types of solid tumors. They were entered into the study. There was folks treated with traditional means or those that were sequenced and got targeted therapy. Those who had targeted therapy had almost a doubling of survival, and they ended up being less expensive to manage per week, mainly because the drugs worked and they weren't admitted into the emergency department or the hospital for excess care. And so this idea that the data can be used across solid tumors, that it can be beneficial in terms of controlling the disease and can actually be cost effective was really important pivotal data in terms of pushing this into the mainstream and becoming a normal part of care. Now, part of the reason why we do this is that there are large numbers of drugs available in some countries, certainly in the United States, where we know that patients with a certain genomic alteration will benefit from those agents. There's usually a tumor type that the initial studies were done in, but then there are subsequent studies demonstrating that this works across tumor types or works in the following other tumor types. And so you have opportunities to, when you run out of the usual options, to be able to go in and provide a level of benefit that you wouldn't normally achieve just by using the standard therapies. And we'll come back to this piece in a little bit when we look at the longitudinal use of this in oncology in a couple of slides. Actually, this slide, excuse me, I knew it was coming, didn't know it was next. So this is an example where this was a lung cancer patient. A core biopsy was performed of their tumor, so a large needle was stuck into the tumor, tissue was obtained, the DNA was extracted from the tissue. It was then run through sequencers and identified two major changes. You can see there on the slide, an alteration in the epidermal growth factor receptor and an alteration in the p53 gene. Well, the EGFR example is associated with the therapy. And so the patient was started on a medicine called erlotinib. At that point in time, that was the standard approach you would take for this therapy. And then a few months later, we did what's called a liquid biopsy. So if you can't get a needle into the tumor, or you're not surgically resecting the tumor, one can take a blood sample and then look at circulating free tumor DNA that's in the plasma of the sample. And so you look there, and you don't know where the cancer is coming from. It could be all the different lumps and bumps are contributing to what's in the plasma, but you can measure it there. And in this case, the patient had some extra variations that have now appeared, including the one in yellow, which causes resistance to erlotinib. And so we are able to quickly switch to a different epidermal growth factor receptor that is active even when that T790M variant is present. And so again, the data allowed us to make a switch to overcome resistance that had now mounted based on the therapy. Well, a few months later, we looked again using a liquid biopsy, and we found additional mutations had happened, including the one shown there in orange or goldenrod, which causes resistance to osimertinib. And so, the good news is you now know that there's a problem. The bad news is there's a problem, and how do you deal with it? Where in this case, there weren't any other leads that came out from this data. and therefore we put them on this woman on classical chemotherapy in order to help control her cancer. Well, a few months later, we looked one more time, and now the tumor again is responding to the pressure. Evolutionarily, it's now being hit with attempts to stop the driver, and it's trying to find ways around it, and so it's causing allowing all sorts of mutations to emerge. And because there were so many mutations here, the patient was now eligible for a clinical trial with a combination of immune therapies. They before were not eligible. They didn't have a means to get on that trial. Now there was a means because of the number of neoantigens the patient now had. The patient went on this combination immunotherapy trial, and she's been on this therapy now for over 2 years. So the best we did previously was 4 months. The best we did previously was 4 months. The worst was 3 months. Now we have a therapy that we got to that has lasted for over 2 years. And so I mention that because, first of all, there's technology to follow the patient over time. There's data to respond to that information in a way that is impactful. And in some cases, you have bought enough time to get to a much more potent therapy. And so people say, why bother causing stable disease in a cancer patient? Well, the reason why is we don't know what's going to come next in terms of effective therapy. And there are a number of patients where we kept them alive and in good health till the point where there's now a curative therapy or a hugely impactful, at least, therapy that can really make a difference, like we're seeing with this, this kind of example. And so again, opportunities that we would have missed if we hadn't been able to look like we can now. I'm going to skip this in the interest of time. It's just a reminder that we might have all the fancy technology, but we're still not very good at applying these technologies out in the population. We still have a lot of room to go. I'll come back to that point in a bit. Now, in terms of patient, we just talked about taking a bit of their tumor and sequencing it. You see that on the top part of this figure. But on the bottom part, it's just a reminder that our normal tissues are also driven by genetic variants for many of the variations that we see, and these can be very important for the metabolism of the drugs, the transport of the drugs into and out of tissues, a lot of factors such as that. And so pharmacogenomics, or the interaction between the genome and the medications, is also going to be relevant in terms of the normal tissue, not just the tumor tissue. And so I'm going to focus in on that little box on the upper right there for the next couple slides. Now, why focus on drugs? Well, for one thing, they're an important cause of death. So there's data from the UK, data from the US, demonstrating that somewhere between the fourth and fifth most common cause of death is from adverse drug reactions. Now, it's not one drug. That would be taken off the market if there was one drug. But it is an area that we can do better. It's heavily litigated, so if you live in a country like the United States where litigation is a little bit too common, it's an important thing to try to avoid. And then many of these adverse events can be predicted. And so, especially in the context of expensive therapies, we can do better. This idea that we just try it and see was okay when we didn't have a lot of choices, but we do have choices now. We need to be better at figuring out what we're going to do. This is just a reminder that not only is there a large cause of death, but there are a lot of patients who have to be admitted to the hospital, a lot of patients who have to go to the emergency department. It's millions of people per year that are suffering from these adverse drug events. And so if we can be even a little bit better than we are now, we can make a huge difference in terms of a lot of people's outcome as they're trying to live their best life. Now, in terms of pharmacogenomics, this is not something for the future. This is something that we're doing now. And there's a number of examples where the US Food and Drug Administration has included genomics in the dosing and administration section. Now, there's examples in about 170 different drugs where genomics is somewhere in the package insert, the drugs dossier. But these are examples where it affects dosing or administration of the drug. And some of these are tumor markers, like you just described. Others are affecting everything from cystic fibrosis to hepatitis to AIDS to to fungal infections and can be important. And even in an area like cancer, a narrow area that I just described, we see that it's not just the tumor, but many of these patients have pain control issues. Many of them have vomiting issues from the medicines and from the surgical, from anesthesia, more specifically. Many of them need antidepressants because of their therapy, because of their disease, because of their personal condition, and the list goes on. And so, again, managing patients requires managing the whole patient, not just their tumor, or not just their virus, or not just their transplanted kidney, as we're trying to move forward. So here's an example of how the science turns into practice. So this is an antifungal drug. It's used to treat all sorts of different fungal infections, and it's used to prevent fungal infections in patients who don't have the white blood cells to fight it on their own. So one area that I use it is in the context of myeloid malignancies, where we go and use this data to use voriconazole to prevent fungal infections, which are often fatal if you get them. Well, this medicine, as you can see here, is metabolized by several different genes. Don't worry about the gene names; they were named based on an old convention and don't have fancy names. But you can guess that the one that's in a large font and in the red color, the CYP2C19, is the most important one. And indeed, it breaks down voriconazole to inactive products. So if that gene is revved up, like what you get with the CYP2C19 star 17 variation, you get more enzyme activity than usual. You get rid of voriconazole very fast, and you don't get the level of benefit you desire. And so a number of studies have been done, and you can come up with relatively straightforward algorithms. This may not look straightforward, but it is. It's basically, if you don't have any gene variation, you get 200 milligrams twice a day, or BID. If you have one of your genes variant, you get 300 milligrams BID twice a day. If both copies of your gene are jazzed up and you're going to get rid of voriconazole too fast, don't even bother. Go straight to a different antifungal drug, and then you'll get the level of protection that you need. And again, Dr. Kevin Hicks and others have done studies to look at this. This is some data that was published last year demonstrating that when you don't intervene, about 40% of the patients are in the target blood level range. If you intervene based on genomics, it's now over 80%. There's still a few people that have low blood levels, as you can see here. And we're not sure exactly why they have that, but we're trying to figure it out. There was one patient that was above the bar, thankfully did not have toxicity. But this is about 1/3 of all patients that will have something that needs to be done. So it's not a rare indication. It's something that's common and needs to be helped with. And so this sort of thing is an example how we do the science, turn it into routine practice, such that we're routinely using precision medicine to guide even things like the antifungal drug, not just choosing the therapy to try to cure the cancer. We also have done economic analysis, and this is really important. If you want to make change at your institution, at your environment, don't forget that there are people who only care about the dollars, whose main job is to care about the dollars. And so include economic analysis, practical economic analysis. We didn't look at quality adjusted life years or something that is more of an academic endpoint, but rather looked at endpoints that they can relate to. In this case, in terms of saving fungal infections, we did analysis demonstrating that if you have a fungal infection, it costs about $30,000 extra in the first year per patient. And so therefore you can save a lot of money by just preventing a few fungal infections. And so that's the type of thing that helps the non-science decision makers be on your side in terms of implementing precision medicine. Now we have a large number of different guidelines now going across a number of genes, a number of drugs. Some of the genes, like the CYP2D6, there are a number of classes of drugs that are involved. And so within each class, there'll be multiple drugs. We're talking about over 100 drugs total. Other times it's just one drug or a small number of drugs that's being influenced. But the concept that we have guidelines that can be important is there. And when we're using panel testing, where we have a number of genes on one test, we often are getting data from all of these areas. And so we may have ordered it to optimize the antifungal therapy, but we also can use that same data to optimize the depression therapy, antidepressant therapy, whether they have esophageal reflux disease therapy that works, cardiac therapy, etc., going forward. So it's a broad application. Now, I want to briefly mention the example in the neonatal intensive care unit in the NICU, and then we'll move into some final pieces going forward. And this concept that in the neonatal intensive care unit, a rapid whole genome sequence analysis can be performed is really quite remarkable. Stephen Kingsmore and the group at Rady Children's in San Diego pioneered this work. Now it's been trotted out across California. Now it's across the United States. I'm sure many other countries are doing this or will be doing this. But when you do the rapid sequencing of these babies in the neonatal intensive care unit, first of all, it's less than 3-day turnaround to get back the result. At Rady, it's even less than 26 hours as they're doing this. You about a little bit more than half the time, you find something that's actionable. It might be actionable identifying a high risk of heart failure, for example, and the baby can go straight onto the cardiac transplant list. It might be something more simple. So we had one baby who had lots of seizures. They couldn't figure out why anti-seizure medicines weren't working. The sequence data revealed that she had an alteration in the absorption of one of her B vitamins. We now gave her high doses of that vitamin. She stopped having seizures. She got discharged from the NICU. She's now on track to lead a normal life, all because of an over-the-counter medicine that we never would have thought of using in the clinical context. And so again, as we're applying this work, lots of opportunity to think about how do we help people we didn't even expect to help because of genomics. Now, one little piece that I have to mention is that this new paradigm of applying genomics is a lot. Most of the clinicians, the physicians, the pharmacists, the nurses, nurse practitioners, physician assistants, etc., most of them have not been formally prepared to handle the genome. Even a lot of medical geneticists are not formally prepared to handle the type of data we get from a whole genome analysis. And so there's a lot to understand. What is the clinical need? Which test should you order? Does it affect the drug? If so, yes, no. Clinical trials. What do we do with the results? How do we get it into electronic medical record? All sorts of elements that make it very difficult to apply. And so we need local champions. We need interpreters, as I'll show you in just one slide. So just to hit this home, here's an example from a cancer tumor that was sequenced. The data comes back. This was an FDA-approved test, by the way. First, you see that there's no alterations, but then you see a bunch of alterations down there. And then on other pages, you see more alterations and more alterations. Well, what do you do? What should be done? Well, in addition, the laboratory didn't know that the tumor was sequenced recently and from a biopsy that was recent, but the patient was originally diagnosed 11 years ago. And this is tissue from the third resection. They've had prior radiation, prior temozolomide, a drug that can cause DNA changes. So a lot of context is not available to the laboratories. The clinicians reading these tests are not necessarily sure where to look. There's data in this case on page 42 and page 43, in addition to the page 1, et cetera. And so what we're seeing now is a model where we really need some additional help. So if you order an MRI, a radiologist can have your back in terms of those questions I listed. You want to get a biopsy of tissue, the pathologist can have your back in terms of which special stains, how should it be handled, et cetera. If you order comprehensive genomic profiling, whether it's for cancer or for some other area, often you're on your own. There's no one with radiologist level expertise in terms of that example that can step in on the genomic side. And so we're seeing work being done to complement the outstanding laboratory options that are there, where you get this beautiful pathology report that comes out, but it doesn't have the medical translation that a medical oncologist, for example, needs. And so we're seeing groups come in and do that medical translation. So in this one example, which I have the disclosures listed there. In this example, the sample sent to the laboratory, the results come back to an expert group of precision medicine experts, of which there are only a couple of handfuls in a country like the United States. These experts review the case, come back with a short report that really, in 30 seconds or less, they can see what they need to do and move on. And so this idea where you can have a medical interpretation that complements the pathology interpretation is often completely missed. Most of the time, pathology thinks that they've built the complete bridge, and they built a wonderful bridge. You cannot do it without their expertise. But there's still more to happen, and that's one of the reasons that have been identified why there's insufficient testing occurring. No one wants to order a test that makes them feel dumb, that they don't know exactly how to interpret in terms of the reporting. It's also a reason why people are missing opportunities in terms of which therapy a patient should receive. So what's next? That box has now appeared there. Last little piece is we need to be doing work to discover the next operation. So this is an example from our own health system. We have something called the Heredigene study. This is a study where Intermountain HealthCare is looking and it is working with Decode Genetics out of Iceland. This is one of the largest genome projects ever, certainly one of the largest population health genomics studies that have been done. We're about 120,000 patients into the 500,000 that have 120,000 have had their whole genomes sequenced, and we're already finding some very interesting relationships between the gene variants and phenomena that we didn't even expect to necessarily be genomic in nature. So, for example, a publication came out recently looking at the genetics of vertigo. Well, I would have bet money that vertigo had no genetic basis. It was all a physical, chemical, calcium crystals were breaking down in the ear, and that was all it was. But no, there are genetic predispositions. Those are now being evaluated further to see, what do they do? Do they respond the same to treatments, to other therapies? Are they more expensive to manage amongst the different genomic groups, et cetera? All the way leading to prospective testing to try to prevent this. And so this idea that we can now go in, look at many other areas of medicine with an adequate amount of patients to really answer the question is an important element going forward. And so a key piece of that is working with the different disease groups. And so we might be shepherding the genomic analysis, but working very closely with our cardiovascular colleagues, or women and babies colleagues, or our ICU colleagues, et cetera, to try to make sure that the phenotypes, the clinical findings that they see, that they care about, are refined to a sharp point and then can be used in the genomic analysis so that we're finding things that will actually benefit them rather than doing fancy science and publishing it in a big journal, and then nothing happens in terms of actually helping a baby or a grandma or anybody in between. And so again, important information. So right now, this analysis has gone across the United States. It currently has examples in 49 of the 50 states. So if you're from Delaware, please come over and enroll. So we have all 50 states. And you can see just blowing it up in the mountain states, we're covering Utah quite nicely, but also have a lot of coverage around the mountain states as we're going forward in terms of what we're analyzing. So it's, again, a nice population health approach where we're looking at a population, identifying what risks the individuals in the population have, and then doing something about it. So we've already found, for example, some long QT cardiovascular problems. We identify those, though we know they're in trouble. We can go back in there, find people who did not know that they have this risk, and the risk is sudden death. They will just drop down dead. It's a big problem. And so we've been able to go back, identify people in the population with informed consent, discuss it with them, and in many cases, put an implantable defibrillator in their heart so that they will not have to experience diagnosis by death in terms of the way forward. And so many examples happening where we can look at populations, make decisions based on that, and then move forward. So going down to the second to the last slide, and I'll finish up. And remember, there's time for questions. Please do put in your questions as you're able. You have examples where we're selecting really amongst equal therapies. I mentioned the high blood pressure example. It's true really for most areas. You have a number of equal options of therapy. When you look at a Lancet study, or New England Journal study, or whatever your favorite medical journal is, you'll see that there's one arm of a trial that does better than the other arm. And you say, oh, there's the winner and there's the loser. Well, really, we're talking about first line and second line therapy. The winner, the new best therapy, we'll use it first. If that doesn't work in a patient, we don't go to them and say, I'm sorry, winner therapy didn't work. We're going to try loser therapy for you. No, we go in and we say, here's first line therapy, here's second line therapy, ready to help you, and then use that. So just changing our mentality about interpreting trials is important. Rational therapy, risk mitigation, et cetera, all these things are important for influencing the payers. And this is not a USA problem. This is an everywhere problem. If you're in the UK, or if you're in Japan, or if you're in somewhere in South America, wherever it is, Europe, wherever it is, there is someone that is making decisions about which medicines are available, are paid for, and et cetera. And that needs data. And so we need to have those robust data to make those decisions. Jumping to the second to last button, toxicity. Often we focus in on what I think the toxicity is, not what the patient thinks the toxicity is. And so we need to be relying less on the clinician, less on the researcher, more on the patient, for them knowing what is your level of pain, what is your level, your neuropathy, what are these problems, not just what do I perceive them to be, and that's an important part. But if we're ever going to get to that goal of having an ability to optimize benefits and minimize risk, we need to be looking in the proper way in order to do that. Now, I want to leave you with one last slide, just to kind of tickle your brain a little bit. It's common for us to be thinking about the genome and how it applies in different ethnic groups and all that kind of stuff. This is the professional golfer Tiger Woods. So if you were to focus in on Tiger Woods using ethnicity or race as an important driver, what would you pick? Well, in the United States, he's known as a famous golfer, but also a famous African-American golfer. In a lot of the rest of the world, he's a famous Asian golfer because his mom was Thai, and so he has his most common ethnic or racial group is Asian. He's from Thailand. He also has some African-American and some Native American that are there. And so if you're trying to use ethnicity to guess how to help manage Tiger Woods, you're almost guaranteed to be wrong. But if you look at his individual precision medicine profile, in this case a pharmacogenomic profile for this slide, now you know his risk, regardless of what label you stuck on him, and you can then apply it as you're going forward. And so just a reminder, the reason we're trying to get to the individual patient level, even when we're thinking about population health, is because many of the labels that we stick on people have no medical relevance or minimal efficiency of medical relevance. And so if we want to be precise, we've got to actually do those studies. So I'm going to go ahead and stop at this point. We have plenty of time for questions, and I'll turn it back over to Professor Valdez for her moderation. So thank you very much.
And thank you so much, Dr. McLeod, for that informative presentation. We will now start the live Q&A portion of the webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. We already have some questions coming in. Our first question, what are the big gaps for a routine application of precision medicine?
Well, thank you. There are some serious gaps for precision medicine. One is the technology. Not every place has access to the technology in order to do this work in a timely fashion. There are many companies now and laboratories that will help with that. But we're seeing now a lot of health systems in particular start to bring in the technology in-house so that they can have that sort of work. A major gap is in the actionability, as I like to call it. I'm not sure it's an English word, but we use it anyway. In terms of what do you actually do with that? And I alluded to that in the slides. Who's the equivalent of a radiologist for genomic medicine? Some places have a medical geneticist, and certainly that's a major important part, but most places don't have access to that. And so understanding who is going to have your frontline clinicians back is just critical. We should not be expecting that every primary care physician, every nurse practitioner, every PA, every pharmacist should have to understand genomic medicine in addition to all the other things that they have to understand. You know, medical literature is doubling every 70 days or something like that. You can't keep up. And so you need to have high level expertise available. And so we're seeing health systems that don't have that expertise reach out to other health systems that do in order to get that support, reaching out to companies that provide that. But a major gap there is really on the application side, because you can send out your sample to get sequenced, but then knowing what to do with it is still a problem. Right now, patients love the idea that their genome will help drive their care, and so not a lot of major issues there, really across racial and ethnic lines, still not problems. The most clinicians understand that there's a genetic basis to problems, and they're willing to take the data, but they just don't know what to do, and so that's a critical one. And we're training now PhD biologists and genomicists in order to be variant scientists and really have activity in the clinical interface. And it's exciting for them because they wanted to help people in a more direct way. But it's also opened up a new job area for PhD trained people in the biological sciences.
Thank you so much. I want to thank our audience for these questions. Is there different roles for precision medicine in public health versus population health?
Yeah, thank you. That's a very common question that comes up, because these terms get thrown around and they kind of seem to mean the same thing. What's the difference there? From a public health standpoint, there's some practical differences. First of all, often public health has some shorter timelines in terms of acute problems that they're trying to solve. And it's not necessarily chronic disease, but more acute problems. Think about the pandemic. It's been the public health system that has tried to help us. Hasn't always succeeded, but at least they've been trying. Public health is also just looking at factors that affect the majority of people and a large group. For population health, one can look at a smaller group. So maybe it's not the entire population of a state, but maybe it's a population of a health system or such, and look and say, well, what are the things that are happening in our people that need to be addressed? So we might have a patient that has a risk of Parkinson's disease and breast cancer and some other issue. All three of those things need to be dealt with in a population health model, whereas really only one of those would be currently dealt with in a public health model, and that is mammography for breast cancer. And so we're seeing some differences in terms of the focus. A lot of the same people, so there's certainly overlap there. But with population health, usually it's health systems as opposed to public health offices that are trying to do that work.
Thank you so much. And we have time for one more question. There are a few precision medicine experts around. How does a health system even start to help their parents that way?
So helping the patients it's really this. I've alluded to this a couple of times, but I'm glad you asked it. Glad it was asked directly. I think that the practicality is often ignored by those of us who spend most of our time on the academic side. We're delighted to discover something, to replicate it, to look at how it might be implemented. But for a health system, they're doing that backwards. They want to know, all right, who's going to deliver this? Who's going to be able to have that going forward? And if they don't see anyone in their system, and they can't see anyone that they could hire, they just don't do it. And so part of the lag of new technology and innovation in healthcare is that problem. There isn't that person at the pointed end of this that's going to be carrying the load while the health system catches up. We have many things that we do routinely across medicine that used to be a very specialized area, was only done. I mean, right now, even MRI, MRI scans are used by a number of different people. It used to be only a small elite group would order them because of the lack of expertise. Now they're used routinely. A lot of the precision medicine techniques are in that early days phase where there may be no one. And so one of the things that health systems have been doing is, and I mentioned this a little bit already, is reaching out to other health systems. So I happen to be at a health system that has a lot of this expertise. We get a number of people that are reaching out and saying, all right, how does my health system have this sort of approach? And really, we've used almost an airport type model where our health system can be the other health system's control tower, where they're flying the planes, they're in control of that, but we're helping them stay on the ground when they need to be on the ground, stay out of other airplanes' way. You'll get success in that way. And so it's really an important part and so we're seeing now centers of excellence helping out centers that don't yet have that expertise, helping train some of their people, but also literally helping on a person by person basis moving forward. So precision medicine, lots to do on the science side, but there's also a lot to do on the practical side if we're really going to make this real in terms of helping grandma.
Dr. McLeod, thank you so much for your time today and for your presentation. Do you want to provide any final comments for our audience before we go?
Thank you. I know it's a real diverse amount of expertise that are participating in the Labroots sessions. And so I just encourage you to think about your area of expertise. What is it that you're doing? And how could we be more precise in that element? It could be that you're on the technology side or the computational side or a clinical side, who knows? But the idea that this can go forward. If you're in a country where this seems like a fantasy, well, think about reaching out to countries where it's not, and work with people who are going to help your country make this a reality. And so really, regardless of your lens that you're watching this from, I would encourage you to think about how do we make precision medicine happen and make it real? Because we so need this if we're going to really control all the disease that we're now able to diagnose in the most meaningful way.
Absolutely, and I want to thank you again for your time. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time today or those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand for 2 years until April 21st, 2024. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Bye-bye.